Health Friday conversation. Every Friday, we do this. Now, we cannot go into the end of October and we do not discuss what happens in October countrywide and globally. It's a Breast Cancer Awareness Month. And so this morning, we are privileged to have Professor Mansoor Saleh, who is a consultant oncologist at the Aga Khan University Hospital, to come and tell us more about breast cancer in this country. Prof, good morning.
Asante, thank you. Thanks for having me again.
Good to have you back here. You're looking well and healthy.
I'm trying.
Very good. Very good. You the day's proverb.
Yes. Our proverbs for the last 3 weeks, including this one, have been from countries of the Maghreb. This week we've been in the Republic of Tunisia. Okay? This is Africa's most northernest country. You don't get more north. One would argue it's the true north, is it? Tunisia. He who spends a night with chicken will crackle in the morning.
He who spends a night with chicken will crackle in the morning. You said this is from Tunisia?
Yes, it is from Tunisia.
Okay. Prof, what do you think?
I was prepared for something when I came here. So I've talked to ChatGPT to say, how do I respond to these questions? I think it is true that the environment in which you find yourself can be reflected upon you. So it's quite possible that if you sleep with a chicken, that you might behave like them as well. I think that infectious energy can be positive, but also can be negative. And you see it around this country as well. Somehow, we need to find a way to crackle with the kinds of chicken we find like-minded, as opposed to with every chick who is out there. So that would be my interpretation.
Choose your chicken wisely.
Yes, so that you can crackle appropriately.
Yes. And lay the right eggs.
Yes.
Prof, thank you very much. That's a good one. That's a very good one. Why was October chosen to be the Breast Cancer Awareness Month?
I must admit, I do not know the history. It may well be that the first group that was put together this way in North America to talk about breast cancer, it happened to be in October, but I must admit, I'm not quite sure why. We have many months dedicated to different cancers. Why October was breast cancer, I'm not quite sure, actually.
Okay. So what happens in the month of October?
I think we just draw attention to one disease, which is the most common disease for women, and also the most common disease in women who have cancer. And breast cancer is the leading cause of cancer in Africa, as it is in the West, but also the most common cause of death. And so we want to highlight this disease and the fact that we can prevent, early detect, and today even cure. But we need to always be sure that we do our part, that the population does their part, which is why we draw, I think, attention to breast cancer in October. But I think we should be doing it all around the year.
Yeah.
But October becomes at least a focal month for that.
Okay. So we elevate the conversations about breast cancer. Do you think we've done a good job in this country, in the last couple of years, in terms of just highlighting the issues around breast cancer, creating more awareness about breast cancer?
I think we are better than we were before. But the downstream effect is that we do not have enough resources when you identify breast cancer that we give our women the appropriate care. Either there's not enough funding from the federal government, or even when today we have more patients being diagnosed with breast cancer, they still come too late to us. The mganga on the road will stop a woman and tell her about issues that may not be quite relevant. So the awareness on part of the community is not there. It's still lacking. The awareness on part of the physicians as well, the general physicians, about what can be done about breast cancer. We still think this is maybe TB, maybe it's just a little infection, maybe it's a fibroadenoma, a benign lesion. So I think across the board, we are better, but we're not good enough.
Okay. So there's better awareness, but we're not doing well in terms of just providing access to screening services, then access to early treatment and comprehensive treatment.
Correct.
Okay. Are we seeing more people presenting themselves for screening?
The answer is slightly more. We have many cancer centers, quote unquote, around the country in the last year or so, and they provide services. But just because you provide a service does not mean you're providing good care. A good mammogram has to be read by a good radiologist. It's not the X-ray. The other day I saw a woman who had a mammogram which was read as benign, Turns out 4 months later, she comes with aggressive breast cancer, where the mammogram missed the lesion, but also missed the armpit, which has to be included in the mammogram, because that's where the breast tumors will spread. Well, how do we train the technician to do it right? How do we train the radiologist to be sure that that mammogram should be repeated? So while we are there, we're getting better, we were not good enough. And I think that should be the message we have for this month.
Okay. Then the other bit of the question, again looking globally, is we now even have a National Cancer Institute. And we know that you, Prof, and others at the Khan University itself are leading in research, just trying to understand cancers and the cancer prevalence in Kenya. Are we getting anywhere closer to actually having statistics? Do we know the number of people who have cancer at any one given time in the country? Do we know the areas that have higher prevalence? Do we know any of these things? Are we starting to get that information?
We are getting better. Clearly, before, when you look at Global Scan, which is the international scan to tell you where you have the hotspots for cancer, there were guesstimates. Today at the NCI, I must give them credit. We have a database, registries where all hospitals, besides reporting cancers to their own institutions, are feeding into the database. So I think we have data which is much more accurate that says certain parts of the country where people do have certain lifestyles have a high rate of breast cancer or esophageal cancer or lung cancer for that matter. So I think we're getting better. And that is critical in order for us to apply specific resources to specific parts of the country because of environmental or genetic predisposition, why certain people in the Tenvik area will have more esophageal cancer. What is it about that part of the country? And I think we are getting better, and the NCI should be credited for that, yes.
Okay. Men also have breasts.
Correct. Men have breasts. The proportion of breast tissue in a man is maybe a tenth, maybe even less than that. We talk about breast tissue, not the tissue which is more adipose tissue. It's the glandular tissue. So men have breast cancer maybe a tenth to a 15th of the rate you will find in women. And it's proportional to, one, the amount of breast adenoid tissue, but also the fact that it happens late in life. Even men produce estrogens. And when you stop producing testosterone as you go older, your estrogenic power is higher, which is why men develop breast cancer late in life. Women in Africa develop breast cancer early in life. And that is a problem we face, probably because of the genetic makeup in African women. And we have good data to suggest that the tumors we see in African women are different, even though histologically under the microscope they look the same as in the West. The genetic makeup of that lesion is different. And it's well worth assessing and researching that, which is why we at AKU are specifically dedicated to doing research on patients in Africa as opposed to accepting things from the West that may or may not apply to us.
You say that on this continent, cancer or cancerous cells are detected in women at a much younger age.
Correct.
When you say younger, how young?
So if you look at it, the American Cancer Society used to say you start mammography at the age of 50 because most women who develop breast cancer will develop it above the age of 50. And that makes sense. In Africa, 20%. In Kenya, 20% of breast cancer are detected in women who are below the age of 40.
20%?
20%, 1 in 5.
Wow.
Now that is young. These are young women, premenopausal, early mothers, so it impacts the entire family when a young woman develops breast cancer at this young age. But that can be detected by mammography. Mammography rates are said initially to be start mammogram at the age of 50. Just about 4 weeks ago, even the American Cancer Society said, and we abide it here as well, start your mammography at the age of 40, specifically for that particular reason. But more importantly, every woman, every month, at the same time, when they shower, should be examining themselves just naturally so that you know your body. Because 1 in 10 lesions in a woman's breast that are malignant will not be picked up by mammography, will be picked up by the patient themselves. So know your body. Next time I come here, give me a proverb or a prosa or a rhyme about know your body, because I think we need to know our body. And I think if women did that religiously, An added mammogram on October, when things are much cheaper, AKU has an ad to say it's subsidized. All other hospitals have it as well. You need a mammogram every year from the age of 40. When you're above the age of 50, you could do it every other year. But in between, you go and examine yourself very thoroughly once a month. That is very protective. We also know that you can prevent breast cancer. Breast cancer is driven by estrogen. Estrogen is like the fertilizer for breast tissue. So tumors have an estrogen receptor, which is like a molecular mouth through which estrogen is like the fertilizer. So as you are getting more obese in life, more estrogen being produced, higher risk. So I think a way to prevent breast cancer is low fat, high fiber, exercise. But you can't do that when you are 50. You have to start when you are young. That will change the paradigm in Africa. That, combined with self-examination and mammography, should reduce our rate significantly if we did that properly.
Low fat, high fiber, exercise.
Yes.
And this is, and you said that if you are bigger, then you are at higher risk.
Correct.
Please explain.
Because fat tissue produces estrogen. And if estrogen is a fertilizer that feeds the microscopic mouth of a tumor, you can imagine obese individuals make more estrogens, more fertilizer. The likelihood of a mutation occurring in your breast tissue is much higher. So today, for example, in a premenopausal woman, the main source of estrogen is the ovaries. So if we have breast cancer in a woman who's premenopausal and their tumor is estrogen receptor positive, we try to shut down the ovaries. Either you can remove the ovaries, which is not a healthy way to do it, or we give you a medication. In a postmenopausal woman where the ovaries are not making any estrogens, it's the adrenal gland or fat tissue that is the source of estrogen. So an anti-hormone treatment for a postmenopausal woman is stopping the adrenal gland and the fat tissue from making estrogen, a different drug than you would give to a premenopausal woman. All those information readily available. Knowledgeable oncologists know that, but it tells you that the driver of breast cancer in women partly is the estrogenic drive.
So are we therefore saying that the findings about the age at which cancer or the cells are detected with African women has something to do with their production of estrogen?
You see, it may not be the only reason, but certainly it may be one of the reasons. The other reason that may be our genetic makeup is volatile, and we do not know why. So you have the environment, you have diet, you have your own estrogenic potential. All those seem to add up that the genes we have that are different than the Caucasian genes may be triggered and in a way irritated, and all of a sudden a cell that is growing normally gets mutated, grows rapidly, spreads, metastasizes, and that's cancer.
I've got to ask, Doc, what's a mammography?
Tell me.
What's a mammogram?
A mammogram. A mammogram is a specialized X-ray which develops rays that penetrate the breast tissue to be able to identify those breast glands that may appear to have a malignant potential. They have microscopic calcifications, they are irregular, and you can do that very well with an X-ray that looks at breast tissue. Importantly though, in a woman who has breastfed significantly, maybe large-breasted, the breast is dense. 1 in 5 women, a mammogram may not be able to penetrate the breast tissue adequately. They may need an MRI. But the mammogram is today the breast detection of choice for breast cancer. And if you find a lesion to identify is it really highly potential for malignancy, then you do an ultrasound.
Are there dangers associated with mammogram?
The answer is no. Today, the amount of radiation that you receive when you're having a mammogram is very, very minimal. And when you have a mammogram once a year above the age of 40, that is really a minuscule risk compared to the benefits you will reach. Yeah. And we shield the heart, we shield the thyroid gland, so we are sure that we protect you when you get your mammogram done. It's uncomfortable because you're going to squeeze the breast onto a table so that you get the tissue very flattened so the x-ray can go right through. But I think that pain is worth the effort because it can save lives.
So you lie face down.
You're standing. In fact, this comes to you as a tray. You put your breast on the tray. Another part of the tray squeezes the breast down, and the X-ray comes right through. Yes.
How long does that session last?
Oh, I would say the X-ray is seconds. Preparation may be a couple of minutes. And if you've done this before, you know exactly where to stand. And there is no question. If I squeeze any part of your body, and you know as a man or a woman, it's going to be a little bit uncomfortable.
Okay.
But that pain is worth the gain, for sure.
How does it then work for small-breasted women and men?
Well, for men, it's going to be very difficult. Most men will pick up their breast cancer by palpation. And then we'll do an ultrasound. That picks it up very well. For small-breasted women, we have the technology allows us to really put the breast on this table. But in those women, maybe ultrasound might be better if you can't get your entire breast as well as the axilla onto that particular platform where the mammogram is done. All possible with the right people, the right technicians.
Over the years, and very many people have come to you, whether they're coming for treatment or they're coming for advice, or do you think that people actually know how to learn their body?
We're getting better because people are becoming more aware about their body because of fashion, etc. But awareness for the particular purpose of early detection of lethal diseases, that awareness is not there yet. And I think if we change our mindset, for men, it's about prostate cancer, and we're not talking about prostate cancer today, but often a man having a decreased stream of urine will say, well, maybe I'm not, age, maybe I'm not straining enough. Well, it could be enlarged prostate, which is the majority of the men, but within that enlarged prostate could be a prostate tumor. Well, we don't think about it that. We are much more driven towards the sexuality of a breast, to the potency of a man's virility, but body awareness for health purposes is not there yet.
How can we get there? Because I hear this all the time. Oh, just learn, touch your breast, touch yourself, feel. If you feel something different, then you'll know. How do I know what's different?
Yeah.
How do I even know that this thing was not there last year? Do you remember if I went here last year? How do you know these things, Doc?
How do you know you've got a pimple on your face?
Oh, you see it.
Yes, you see it. You shave, you feel it. You say, this wasn't there before. I think that awareness is critical. How do we know that this dress looks good on me as opposed to the other dress? Oh, we know. There is that awareness. Say, that pink looked better on me than the other one, green, that I wore last time at the dance. I think all of us, if we are really aware, and we are, and we have to just pay attention, and you feel it, it's there. All of us, are we sure was it there? Well, then maybe it was there. Well, next month, it's become a little bit bigger. Look at the colors change. That awareness is different than beauty awareness. If we were to spend as much time in looking at our bodies as an object that clearly harbingers malignant conditions, breast cancer, cervical cancer, pancreatic cancer, colon cancer, etc., I think we'd be much better off. We have all kinds of ads pleasing us to say, buy this dress, take this makeup, do this for your body, you look young, take Botox. I think we don't have ads to say, pay attention to your body for the sake of your wellness and longevity. That to me would be important.
The advent of cancer is still new for many people on this continent. And it's a disease that is associated with other parts of the world, not necessarily here, but now it's with us. And some of the detection methods that you suggest are also alien.
Correct.
When I take a bath, I don't go into the process of massaging my breast and determining whether there's a lump or not. But now I'm being told it's something you need to do so that you understand. Now, the question is, how do you get people to understand the processes by which they can actually get to understand the early detection, and by so doing prevent the eventuality which will not only be costly but actually harmful to them?
You know, there's the good and the bad. We have more cancers today because we live longer. There used to be a time when African women and men were dying in the early 30s and early 40s. Today we live all the way up to the 60s. So the longer you live, the higher the chance that a malignancy may develop because you've got a mutation. You live long enough for that mutation to be the source of malignancy. Otherwise, you would have been dead much earlier. So that's one. Secondly is that our lifestyle has changed. We are not as active as we were before. We use the car, much more smog. Our lifestyle, our foods are very different. And I would challenge, we adopt Western norms very easily. Style, fashion, social media, the food that we eat today are so Western. Then why wouldn't we adopt some of those Western technologies that say we in the West develop a mammogram to be able to detect breast cancer early, or a pap smear? So let's adopt that as well. So I think we as a community, the pulpit in the church and the mosque should be talking about that, as opposed to talk about ethics, about other issues. I think that should be also the bully pulpit that uses this, because cancer affects the entire family, the entire society in many ways. We have less taxpayers, we have pain, suffering. I think that save of economic power would be very beneficial to Africa.
It would. Now, is there a way in which it can be communicated that the process of early detection, one, is readily available in health centers or health facilities, and that it is also cost effective? I ask the question because I know of very many initiatives that have taken place with regards to cervical cancer. I know of something called a pap smear. Okay? I understand it because I've come across it. But the campaigns are on and off. They are not consistent. Now, are we saying that when we have this awareness month, that we are seeking to up the awareness? And if so, how exactly are we ensuring that people who are most at risk actually get to hear and understand so that they can actually take the requisite action?
I think that's what Spice does. The fact you have me here today is a way to say, let's preach to the choir who are listening. Those who listen, hopefully we promote the message to others. And what you say, forget about it just because October is over. However, for breast cancer, at least we should say, in October, I'm made aware, get a mammogram. It's subsidized today. The likelihood of picking up breast cancer early is 9 times out of 10 if it's picked up by mammography, as opposed to picked up by yourself much later in life when you have back pain and you have metastatic disease. So I think you're right. We as a society as a whole, civil society is doing a lot of work. You talk about cervical cancer. I was at a meeting just 2 weeks ago organized by the French Embassy, and the rate of HPV vaccination. Remember, 98% of cervical cancer could be eradicated on this earth if we were to vaccinate our boys and girls from the age of 14 to 18.
Boys and girls.
Correct. Boys and girls. We preach it to the girls, but not to the boys. And the feeling is the case could well be the boy infecting the girl, who then due promiscuity will infect another boy. I think both. Yet the bully pulpit is not being used, and we've called all kinds of excuses about what we would do if we were protected and would be much more free in our own lifestyle. None of that has shown to be true. Cervical cancer, I mean, it's a viral disease. You would think you could vaccinate it. We were vaccinating ourselves against COVID very actively so that we would live, but we've not managed it. It's 28% today in Kenya of young girls and boys even less, who are vaccinated against HPV. We could eradicate this. We do not have a virus causing breast cancer, so the issues there are much more complicated. But at least we have the ability, low fat, high fiber, exercise when you're young, and when you are older, above the age of 40, mammography at least begin once a year, and October is a month where we remind you. And the important thing to me is, it's not just a woman's responsibility. Come, you guys will have somebody here on Valentine's Day to talk about roses, love, etc., etc. We should have the man not take his girlfriend and wife to dinner and spend money somewhere at a restaurant, pay for a mammogram. That would ensure longevity and love for sure.
That's a new way of expressing love. That's a good one. Professor Mansoor Saleh, who is consultant oncologist at the Aga Khan University Hospital, breast cancer awareness, understanding, and knowing what to do about it. So there's a lot that people do not understand. But also you've said it's important it starts with you. Like Siti was saying, some of these things are how we are socially brought up. You're socially brought up to avoid some parts of your body. Now, how do we change that cultural upbringing such that you actually are telling a girl as she's growing up, a boy as he's growing up, it's okay to continuously test and check and touch so that you'll detect a difference in your breast?
I think it can begin early at school, where clearly the human body is being created for a reason. Every part of your body clearly has ails, and we should not look at some part of the body just because they're linked to sexuality as taboo places. So the breast is as normal as your toe, and we don't worry about touching somebody's toes to say if it's hurting. And I think this starts early on at school for both genders, where you respect your body, you clearly know that your body can serve you well, but each part of the body can also undergo certain changes that are critical to be aware of. I think we've spent quite some time about talking about early detection mammography. The one thing I hear often is people are afraid of identifying a tumor, even though they may be aware of it, because the treatment, they say, is worse than the disease itself. Oh, you will cut me, you'll give me chemotherapy, radiation. When I came to Kenya, there are two words I heard in Kenya. Well, I knew them before. Nyama choma, which is good, or choma. The choma is to say, if you give me radiation, you'll choma me. Doesn't exist anymore. We don't choma anybody. In fact, we choma the tumor, but not the patient. So I think we should also bring about awareness of the types of treatment we use for curative intent for breast cancer. Yes, they could be painful, but a short amount of time, but they allow us to really provide cure. And I think we talked about this when I came last time. Just like the breast cancer is fertilized by estrogen, if you have a receptor, which is a macroscopic mouth, that is the HER2 receptor, we can block that receptor because that's also a fertilizer for the tumor. We can cure women today. Recently, we did a study in women with breast cancer who were HER2 positive. We gave them chemotherapy plus anti-HER2 to block that HER2 mouth. We cured all 8 women who came on the study. Nearly unheard of. But you need to have the right testing. Is your tumor ER positive, PR positive, HER2 positive? Not enough to say, I've got breast cancer. Identify the pathology of the breast cancer so that we can then treat you in a targeted fashion. So I think treatment is improved significantly and life can go on. So it is not fair to say the treatment is worse than the diagnosis of the disease today.
You see, right there is where the disconnect is. Because when you speak positively, you speak hope, you speak life. But when we don't have that knowledge, then all our fears and superstitions around cancer is our lived reality. We ask this question over and over, and we're going to ask it again. Do the Aga Khan University Hospital is a teaching hospital? Do we have outreaches or do we have plans to ensure that our school systems benefit from some of these things? We know, for instance, that Kemri Wellcome Trust have a program where they initiate the programs and the processes of research in children as early as primary school and secondary school. So people understand how to grow and mature in research. Now, when people come to hospital, whether it's a pediatric hospital, whether it is for specialized care, their health care providers in these places, is it possible or is there an existence of a training for these health care providers so that when patients come, anytime you go to a hospital or a clinic, you wait. You very rarely do you come in and all that happens is you go and see the doctor. You will wait. That process of waiting, can it be utilized for what is normally called continuous medical education, that people get to be aware when you go there, there's something specific that has taken you there. so that the healthcare providers also know how to inculcate this knowledge during that space of time that is there. And sometimes you're there for a fairly long time. So you're a captive audience.
No, I think you make many valid points. In fact, what you say is we should begin early in education. And does AKU does that? Yes, I think we should do something better. In October, during Breast Cancer Month, we should not just be promoting mammography, early detection, but we should have healthcare providers go to schools.
Yes.
Primary, secondary schools. By the way, did you know there's breast cancer?
Yes.
Do you know this can happen to your mother or your loved one, or to you for that matter?
Yes.
And here, this is how you can protect yourself. Fantastic idea. The issue that we have also is educating individuals while they are in the clinic.
Yes.
While you're waiting for me, we complain about this at the CEO's office all the time. I keep on seeing the TV with all the news. I mean, you hear about Gaza, you hear about this, about that. But what about what I'm here for, i.e. the physician? What can we do? And when we asked the cost of changing that, it was much cheaper to have the TV on as opposed to giving an infomercial. So I think all of these needs to be changed. I think these are great ideas. And I'll go back telling my CEO exactly what you said. Said during Breast Cancer Month, above and beyond us giving a free mammogram or a subsidized mammogram, we should have healthcare providers go to schools, talk to young girls and boys about this ailment, because they can then inculcate that into their knowledge base.
Yes.
And when it comes to research, I think we are agnostic. We have KEMRI here. We have a number of fantastic research institutions, better than most places in Africa. But we should do more specifically in cancer, because cancer research is not something we do automatically. We do infectious disease research, HIV, TB, malaria, but cancer is causing more deaths today than all of those combined infectious diseases. And part of what we do at AKU is exactly that, to say that the genome of a breast cancer patient in Kenya is different. So test those drugs that we have in the West on our patients, do their work, and more importantly, maybe develop drugs here specifically for our patients. And before I finish, I should talk about stigma. We're doing research today on stigma. Young men, young women, and older women who had breast cancer get stigmatized by the outside world. Their husbands leave them because they say they're not as good as you were before. Family shun them to say, by the way, you were maybe bewitched, and whatever you have may be infected upon me. 1 out of 3 women with breast cancer suffer anxiety, suffer depression because of the stigmatization of the society upon them for something they were not blamed for. We need to improve that as well, and that comes from education. So when we go to schools, we should say, just because somebody has a Band-Aid on his face, don't bully him, ask him what happened. Same thing with women with breast cancer. We should really be doing that, and we don't do that often enough. Partly because of ignorance, partly because of fear, what should I tell this person? And we shun them. And one quote I have from a young woman who had breast cancer, she said, in the past, I'd call my friends, I'd say, shall we go out? So they would expect my call. Now that I have breast cancer, when I call, they think I'm sick, I need help, they shun me. That to me is as bad as the disease itself.
And that is, deep-rooted, actually. You'll hear very many people will shy away from going for a test of any kind because they don't want to find out what's there.
Correct.
Because of what it ushers me into, right? I don't know. You're telling me this is a chronic disease, a terminal disease. How am I going to start dealing with these issues? What are you telling me to do now?
Yes.
I don't even have the money, the wherewithal, the mental strength to handle it. And you're thrusting me straight into it. And I took myself there to find out that information. I'd rather not.
Yes.
How do we change that?
I think in the West, I see this phenomenon of openness. Betty Ford had breast cancer. She says, I had breast cancer. Schwarzenegger had prostate cancer. I had prostate cancer. We have a number of influencers who influence society to buy this good or the other good, or buy this dress or this makeup. Why don't influencers who have malignancies come out and say, I had it, I got treated, I'm cured, look at me. Our leadership, in many ways, will go out of the country when they have these ailments in secret. They come back, nobody knew. I think we should have influencers who have these kinds of ailments, including breast cancer, come and talk to say, I'm human as you are. It can happen to me. It could happen to you. Look, I'm here, I'm cured, I'm healed because I paid attention to early detection. I wish we would do more of that.
Is our public health system well equipped to actually deal with these non-communicable diseases that are on the rise?
Not yet. I think if we, with everybody, thanks to Spice, tomorrow we'd have a mammogram, AKU and everybody else will be overwhelmed. But at least then we would respond appropriately and put the resources where they're required. I think we are getting there gradually. We have more mammograms. All the cancer centers in the country that have been opened up don't all have mammography units. But more importantly, it's not just the technology. The machine does not do it. The technician has to be well trained. And once you find the lesion, don't call it BI-RADS 1 when you know it's a BI-RADS 5 aggressive tumor. That requires more than just technology. We buy machines, we put them in the shops, they call them cancer centers. We have to have more than that. And that requires awareness, education, and the right people. We don't have enough radiologists. We don't have even enough oncologists. I think we are getting much better than most other countries in Africa, but I think it'll take some more time to be where we need to be. Awareness on part of the population, but also society as a whole should invest in, one, funding cancer care, as well as then equipping cancer centers with the right people who have the right knowledge.
You know, there's always a discussion, and predominantly that's what it is, a discussion and a talk about preventative and promotive care. And the cost effectiveness of it is also discussed. With regards to cancer, early detection, prevention, what do we tell people? What do people need to know and understand so that they can actually take the steps to ensure that they limit the chances and opportunities of actually acquiring or actually being cancerous?
If you look at the data, if you find a lesion 2 centimeters by mammography, because it's difficult to find by hand, because in the breast 2 centimeters could be very small compared to your whole breast. You pick up a lesion 2 centimeters which is not spread to the lymph nodes.
What is a lesion?
A lesion is like a lump. Yeah, a lesion is a lump. We use the term lesion when you have a lump that you suspect would be malignant, so we call it a lesion. But it is basically a lump. A 2 centimeter lump in the breast, you cannot feed it because your breast has so many other lumps, breast tissue, etc. A 2 centimeter lump, lesion, with no spread to the lymph nodes in the axilla, which is where they go first, the cure rate there is 90+%. You're alive and well forever after. The cost of care would be mammography, probably surgery. If you want to keep your breast, we take out the lump. For the rest of the breast, we have to give you radiation. And then you may need some chemotherapy or hormone therapy. I can imagine, and just off the top of my head, the cost of care would be about totally, let's say, between $6,000 and $8,000 converted to shillings. But you're cured. You come to me with stage 4 metastatic breast cancer, it's just spread to your bones in your liver. Your life expectancy is about 2 years. The cost of care of hospitalizations is at least tenfold higher than what it would have been had you picked it up at stage 1. And the cost between stage 4 and stage 1 is the mammogram, which is today, in October, subsidized and cheap. You can imagine, cost economically, that would be better. How do we convey that in a very layman fashion to the common person to say, it behooves you to save some money and get your mammogram? 1 in 10 women in their lifetime will develop breast cancer. 1 in 10. It's not very uncommon.
Yeah, that's high.
That's a very high one.
That is high. That is high. But you know, if you were to look at the prioritizing of what people in our continent have with regards to healthcare, what competes for the resources that they have? Am I going to eat? Are my children going to go to school? Or am I going to go for a checkup? You balance this and ask yourself, what do you think will win the day? It will not be going for a checkup.
That's for sure. All low middle income societies where you are hand to mouth, which is why the government has to assist, has to improve our culture of care by making food accessible, education accessible, and then these kinds of preventive health care aids be nearly free. And I think we're not there yet, but as we develop, as we become more mature, we will get there. But the trouble is, as we develop, become more mature, we assume, we take on Western habits, which to me are even more a cause to getting us to be more obese, more hypertension, more diabetes, more cancer. So we're developing in a good way in some times, but then also in a bad way, because societal habits are taken up much easier through the TV than these kinds of promotional about early detection and prevention.
Prof, you talked about just getting to do localized research so that we get to understand our cancers, our diseases from our own context. And you and others at the Aga Khan University Hospital and elsewhere are leading this. We had a conversation earlier this week with Professor Sam Kinyanjui from the Kemri Wellcome Trust program, and he mentioned the ALMA program that you're running at Aga Khan University. Tell us about that.
I don't have specifics about what did he say about the ALMA program?
So all of you have come together and there's something about neuroscience and getting to understand just how it's basically just extending research.
Correct. So, today, above and beyond cancer, any other disease, non-communicable diseases, mental health is a big issue in this country, everywhere else. So we at AKU have a Brain and Mind Institute looking at the juxtaposition of neuroscience with mental health and physical health. So we met together. We have a study going on, for example, looking at usual stresses of life and how that leads to brain aging. Brain aging leads to dementia. Dementia leads to, as you know, poor quality of life. So we have a study going on evaluating 200 healthy individuals to see what regular stresses of life, taxes, mandamanos, riots here and there, what do they do to my life? Those are stresses. We do an MRI, we give them a Fitbit, we do neuropsychologic testing, and we assess what's going on over 1 year. And then we say, let's induce a stressor into this framework. So we have 25 women with breast cancer, 25 men with prostate cancer who've been early diagnosed, and we put them on the study. We do the same thing with them to say, now you have the same issues like everybody else, but now you've been diagnosed with cancer, you got chemotherapy, hormones, surgery. What does that do to your brain and your MRI and your Fitbit? And we assess you on a weekly basis. When your Fitbit shows tachycardia, we call you up and say, what's happening? Do you quarrel with your wife? Oh, no, I was having chest pain. Well, let's come and have you tested. That study is the first study in Africa looking at brain aging in the context of stresses of life, but then adding the stress of cancer. That to me is a unique. I just came back from a meeting that was in Europe where that was highlighted as one of the first studies looking at mental health and brain aging in the African context. And I think that is the kind of thing that my colleague from Kemri must have talked about. And there are many other things. We talked about stigma, mental health, neuroscience. I think our dean, Lynn Lukoy, was recently at the cabinet meeting talking about how can we make suicide not a punishable entity, but a mental health issue where we can help individuals. So I think we at AKU, through research, are trying to bring in at least an academic angle to what societal ails are so that we can explain it, study it, improve it, and hopefully improve the quality of life of our people in this country.
I like what you've just said about your dean going to talk to authorities and our politicians about this. Because one of the disconnects that has existed for the longest time is how those who are in decision-making positions are ignorant about research processes, the importance of it, and how it contributes to the very things that they themselves are trying to promote. They are not aware. They do not know. They do not understand. My question, yes, the dean went there once. Do you have a program to ensure that people who make decisions on all these matters are constantly informed and they know so that they keep up with it?
Well, it's a big question, but at least we are getting that ivory tower to go to the policymakers. And as policymakers now elect people who are academically informed, then you have this ability to say both the policymakers understand and the academic tower can bring new knowledge so the two can talk together. I think we are getting closer to accepting the fact that suicide should not be a punishable entity, but at least a mental health or at least a societal concern.
Prof, when you talked about how it is that churches and mosques and religious institutions should help propagate these messages, people who are also in the public domain, and for a lot of the time they are characterized by the nonsensical things they say. That is our politicians, okay? When they are informed about these things, they also get to grab the attention of the populace. And when they know, because knowledge that they can pass on will give them an element of popularity. So it's a win-win.
I agree.
It's a win-win because they'll talk about things which are important, but it's a win-win because they will give the impression to the electorate that they care and they're concerned. So the idea of talking to Parliament and talking to the various, what are they called, committees that they have, whether it's the Senate or whether it's the National Assembly, it's very, very important.
I agree. When I became a physician, people tell me, can you go and talk to the policymakers?
Yeah.
I said, no, it's a waste of my time. I'd rather be in the lab. I realize today that it's just as important to talk to policymakers, influencers, just as important as being in the lab, because if you cannot translate the discoveries of the lab to the common person, and the intermediate interlocutor is the policymaker, then I failed in my mission for sure.
Prof, we thank you very much for coming. Give a final message to Kenyans as we have, the final days of Breast Cancer Awareness Month.
I think my message would be to Maina, the message of hope. Today, a woman with breast cancer has a great potential to be cured because we have effective therapy here in Kenya. Not just at AKU, but all our medical institutions. That's one. So if you already have it, know that we can cure you. Number two, if you don't have it, the best way to do and protect yourself is early detection and prevention. High fiber, low fat exercise, health prevention, but more importantly, mammography and self-examination can ensure that you will pick up this entity early in life if it is going to be destined for you, and that ensures better cure. That is our responsibility, and that is my message.
Oh, thank you very much. Professor Mansoor Saleh, consultant oncologist at the Aga Khan University Hospital. He's been our guest on this Health Friday conversation, awareness, detection and prevention of breast cancer.
This is the Situation Room, the only way to start your day.